Welcome. Thank you for watching Planning for a Better End of Life, a guide to navigating today's healthcare system. In this presentation, I will discuss healthcare proxies, living wills and other advanced directives, palliative care and how and when it can benefit you, how hospice care can improve quality of life, and telling your doctors about your end-of-life care wishes. My name is Lillian Maron, and I am the Director of Outreach and Education at End of Life Choices New York. This presentation is funded through an award from the National Network of Libraries of Medicine Middle Atlantic Region, a partner of the All of Us Research Program. Developed resources reported in this presentation are supported by the National Library of Medicine and National Institutes of Health under a cooperative agreement with the University of Pittsburgh Health Sciences Library System. The content is solely the responsibility of the authors and does not necessarily represent the official views of the National Institutes of Health. End of Life Choices New York is a nonprofit organization, and our mission is to expand options at the end of life, ensure respect for every individual's end-of-life wishes, and strive for the best possible quality of life and a peaceful death. We educate the public and healthcare professionals on end-of-life issues. We provide free counseling to people who are approaching the end of life and their families. We pursue legal and legislative reform to ensure a patient's right to a peaceful death, including implementation and enforcement of advanced directives, pain and symptom management, and legalization of medical aid in dying. Before moving forward, it's important to understand why the topic of end-of-life planning and rights has become so important. Just 100 years ago, dying was a very different process for most people. Then, most people died relatively quickly if they were sick or injured, because for most things there was no cure or way to slow down the progression of illness. However, today we have more cures and treatments than ever before, and through technological advancements we also have life-sustaining measures such as ventilators and other forms of medical support that can extend life for months or even years. Some people want to be kept alive as long as possible, but others do not. Many people fear being kept alive for long periods of time by this new technology, especially if it prolongs suffering. The good news is that the vast majority of people can die a peaceful death if they are properly prepared. If they have created the proper advanced directives, their treatment wishes are more likely to be respected. And if they know how to make use of hospice and palliative care, they are more likely to be comfortable during their final months. So with that, first I will be discussing advanced directives. If you are an adult with the ability to make decisions for yourself, you always have the legal right to request treatments or have your medical treatments stopped. For example, you can tell the doctor to turn off your respirator or remove your feeding tube or stop dialysis, and the doctor must either comply or refer you to a different doctor who will stop the treatments. But what if you have dementia or are very sick and are unable to communicate or make your own decisions? If a patient can't communicate, most doctors will err on the side of keeping them alive. Even if a friend or family member knows what treatments you would or would not want, they may not have the legal right to make medical decisions on your behalf. That's where advanced directives come in. An advanced directive is paperwork that will protect your right to have your healthcare wishes respected if you lose the ability to communicate. With the right kind of advanced directive, your wishes will be known and the chances of their being followed will be greatly increased. There are several different types of advanced directives, with the most common being a healthcare proxy form, living will or other documentation of wishes, a do not resuscitate order, and medical orders for life-sustaining treatment. I will go through each of these next. We strongly recommend that everyone 18 years of age or older have a healthcare proxy, so that is the first thing I will discuss. If you are injured or become ill and are unable to communicate or make decisions, someone else will have to make healthcare decisions for you. The healthcare proxy form is a document that names someone you trust as your proxy or agent to express your wishes and make healthcare decisions for you if you are unable to speak for yourself. If you have not filled out a healthcare proxy form, there is a big risk that your healthcare wishes will not be known or honored. There is a law in New York called the Family Healthcare Decisions Act, passed in 2010. If you don't have a healthcare proxy, it designates the person who has the right to make medical decisions on your behalf. A spouse outranks an adult child outranks a parent outranks a brother or sister, and a brother or sister outranks a friend. However, the person it designates as the one who can make decisions on your behalf may not be the person you can trust to follow your wishes. Maybe you know your spouse would never be able to tell the doctor to let you go, no matter how strongly you've told them that is your wish. Or maybe you don't have a spouse, so a child, parent, or sibling will be the one with the authority to decide. And what if you have more than one child, parent, or sibling, and they disagree with each other? For these reasons, it's much better to have a healthcare proxy than to assume the Family Healthcare Decisions Law will result in what's best for you. Fortunately, the New York State Healthcare Proxy Form is very easy to fill out. The form itself is only 2 pages long and very little needs to be filled in. The document also contains instructions and answers to frequently asked questions. When you fill out a healthcare proxy, you name someone you trust to be your healthcare agent. If you are unable to speak for yourself, that person will make your healthcare decisions for you, telling the doctor what types of treatment you want and what you don't want. The doctor is legally required to follow the instructions of your healthcare agent. You can name a spouse as your healthcare agent, or a child, or a friend, or someone else. But whoever you name, that is who the doctor must obey, no one else, regardless of their relationship to you. The form also has the option to name a second person to serve as your healthcare agent if the primary agent is unable, unwilling, or unavailable to act as your decision maker. Since your healthcare agent will have the power to make your healthcare decisions, it should be someone you trust to follow your instructions. It should not necessarily be a person you are very close to. Sometimes a spouse or child will be reluctant to stop treatments, even if you told them you didn't want them, because they don't want to feel they caused your death by stopping the treatment. It is up to you to decide who is most likely to do exactly what you ask them to do. No lawyer is required to complete the form, and it doesn't even need to be notarized. It just has to be witnessed by 2 people 18 years of age or older who are not the healthcare agent or the alternate agent that was appointed. The form also has optional sections, including a space to indicate your preferences about organ donation and a space to detail your end-of-life wishes. We recommend you review healthcare proxy forms at these times: a death in the family, a divorce, decline or illness, diagnosis, every decade, or if you think you'd like to change your healthcare agent or your views have changed on what you would prefer at the end of life. You should give a copy of your completed healthcare proxy form to your healthcare agent so they can prove they are your agent. It's also important to give copies to family members and doctors. Do not just put it in your safe deposit box or a file in your desk, because if you're unable to communicate, it might not be found in time to be used. You may also wish to consider keeping a copy of it on your cell phone or in your wallet or purse. Since your agent will make medical decisions for you if you are unable to, you must discuss your wishes with them and document your wishes. There are 2 lines of thought about the best way to specify wishes, and it's really a matter of personal preference. The first way is just to state your general wishes without getting specific. For example, you might write, "If there is no expectation of recovery and I am suffering, I do not want to be kept alive by machines." Or, "I want everything possible done to keep me alive." Then you trust your healthcare agent to make the specific decisions that arise in the course of your treatment. Another way is to specify what you would or would not want. It can be difficult to predict exactly what circumstances you will be in if you are ill and unable to communicate. So many professionals advise their clients to keep things simple and let their healthcare agent use their best judgment. However, some people want to get specific about what kinds of treatment they do or do not want. For example, if you have dementia, you may be unable to feed yourself, and so a caregiver may place food on a spoon or other utensil and place it in your mouth. Some people would not want this if it would prolong their lives when they have late-stage dementia. Other things to consider might be artificial respiration, which is the use of a ventilator or other device to breathe for you. Artificial nutrition, which is the use of a feeding tube through your nose and throat or surgically placed in your stomach to help you eat. Artificial hydration, which is when a small tube is placed in a vein through which fluids can be given to you. Cardiopulmonary resuscitation, also known as CPR, is an effort to keep your heart beating and lungs breathing if your breathing or heart stops. Antibiotics are given if there is a known or suspected bacterial infection, but carry some side effects. If your life expectancy is low, you may wish to consider whether you would prefer to receive antibiotics and in what circumstances. For example, you may want it if it would make you feel better, but not if it may make you feel worse or prolong your suffering. These are just some examples of things to consider. These are very personal decisions and there are no right or wrong answers. If you change your mind later, you can always revise the form. Just make sure to let your agent know and give a copy of the new directives. Your wishes can be listed on the healthcare proxy form or in a separate document that can be stapled to the form. Here are some examples of what someone may write on a directive. If I become terminally ill, I do or do not want to receive the following types of treatments. If I am in a coma or have little conscious understanding with no expectation of recovery, then I do or do not want the following types of treatments. If I have brain damage or a brain disease that makes me unable to recognize people or speak, and there is no expectation that my condition will improve, I do not want the following types of treatments. These are just examples, and you should consider the different circumstances that would inform whether a treatment is right for you. You may have heard of a living will. This is a formal written document in which you list the types of treatments you would or would not want under various circumstances. This form should be given to your healthcare providers and healthcare agents. A living will must be honored in New York State if there is clear and convincing evidence that it conveys the patient's wishes. Because of the requirement for clear and convincing evidence, this document is often created with the assistance of a lawyer. Unfortunately, because of this requirement, a living will can sometimes be hard to enforce if there is a question about whether the document truly reflects your wishes and there is no healthcare agent. In New York State, a healthcare agent can make decisions for you, and a doctor is legally required to do what your healthcare agent asks them to do. But if there is not a healthcare agent, a doctor may not follow the wishes you expressed in your living will. So, in New York State, there is currently no way to make sure that the wishes expressed in a living will are going to be followed if it is the only type of advance directive the patient has and no healthcare proxy form was completed. The living will can be stapled to the healthcare proxy form to specify your wishes, but a living will without a healthcare proxy does not fully protect you. Another type of advance directive is a do not resuscitate order, often referred to as a DNR. A DNR instructs medical personnel not to revive you if your heart stops beating or if you stop breathing, but it only covers these circumstances and not other situations. For some people, it is important that everything possible is done to keep them alive, while others feel they would not want to be resuscitated. Reasons someone may not want to be resuscitated include, but are not limited to, if they are terminally ill, or when the likelihood of survival is low due to age or other factors, or they are worried that if they do survive, there is a risk of brain damage that would stop them from returning to the life they had before the incident. These are very personal decisions, and again, there are no right or wrong answers. If you do not want to be resuscitated, you should talk to your doctor about a DNR. A DNR order must be signed by a healthcare provider, such as a doctor or nurse practitioner. It also should be easily located. If an ambulance comes to your home and they do not see a DNR, They will likely try to resuscitate you, no matter what your family members tell them. If someone has a DNR and wants to increase the chances it will be followed, we advise them to post it on the inside wall next to their front door so that if an ambulance comes, the technicians will see it. Another document in New York is called the Medical Orders for Life-Sustaining Treatment Form, or MOLST. The MOLST form was created in 2008, but most people are unaware of its existence. Even some doctors and elder care lawyers have never heard of it. The MOLST form documents your wishes regarding CPR, artificial hydration and nutrition, antibiotics, and comfort care, which is care to relieve pain and other symptoms, as well as other topics. It does not replace a healthcare proxy form. The MOLST form must be signed by your healthcare provider and by you or your healthcare agent or surrogate. Because it is signed by a healthcare provider, it is much more likely to be honored than a living will because it is considered an official medical order. Not all healthcare providers are willing to sign a MOLST, and some of those that are willing will usually only sign it if you're expected to die within a year or in a nursing home. The way it's sometimes put is that the MOLST is appropriate if your healthcare provider would not be surprised if you died within a year. However, there is no law restricting MOLST forms to these criteria. Some healthcare providers are willing to sign them even for people who are relatively young and healthy. If you don't know anyone you can appoint to be your healthcare agent, it's worth trying to have a doctor sign a MOLST form for you, even if you're not elderly or ill. Some healthcare providers might be willing to do this. The MOLST form will have a much greater chance than a living will of being honored in the absence of a healthcare agent. Next, I'll talk about palliative care and hospice. They offer you the best chance at a good quality of life throughout an illness and as you near the end of life. However, they are relatively recent developments in healthcare, and most people know very little about the benefits they provide. A lot of people think hospice is only for the last few days or weeks of a person's life, and that is not the case. If a person starts palliative and hospice care at their earliest opportunity, they can have a much better quality of life for their last months or even years. People often ask about the difference between palliative care and hospice. Palliative care programs provide treatment to prevent or relieve pain and suffering and improve the patient's quality of life, both physically and emotionally. In these programs, you do not have to be terminally ill, and you can continue to receive curative treatments like chemotherapy and radiation. If you have to be hospitalized for a serious illness, we strongly recommend you find a hospital with a palliative care department and ask what services are provided by that department. Some only deal with pain management, whereas others also offer psychological and spiritual support. However, unlike hospice, which I will discuss in a moment, these programs are typically not 100% covered by Medicare, and what is included varies from hospital to hospital, though they may be covered by other health insurance plans. Hospice is a type of palliative care for individuals at the end of life. In hospice care, each patient is assigned a team typically consisting of a doctor, a nurse, a social worker, and a chaplain, rabbi, or other spiritual counselor if that is desired. The team meets regularly to discuss the patient and their needs. They manage pain and other symptoms and offer counseling and emotional and spiritual support to both the patient and their family. Hospice can take place at a center or at home. If you wish to stay at home, hospices can enable you to do this by providing medications, medical supplies, and equipment like a hospital bed or wheelchair, as well as visits by a home health aide. They also offer free grief counseling to family members for up to a year after the patient's death. Hospice care is almost 100% covered by Medicare. If you do not have Medicare, it may also be covered by your insurance. There are 2 requirements to enter hospice. The first is that you have to have a life expectancy of 6 months or fewer. This doesn't necessarily mean you will die in 6 months. There are very few diseases in which a prognosis can be pinned down that precisely. All that is necessary is that your doctor is willing to say, if the illness runs its typical course, you are likely to die within 6 months. Some people are in hospice for years off and on because they outlive their prognosis. The second requirement to enter hospice is that you cannot receive treatments intended primarily to cure you, only treatments to make you more comfortable. Therefore, patients generally enter hospice if treatments have not worked or if they do not feel the treatments are right for them. However, after entering hospice, it is perfectly fine to change your mind. For example, if you decide you'd rather have chemotherapy or surgery after all, or if a new treatment comes out. You can check out of hospice at any time, and later if you change your mind again, you can re-enter hospice. We encourage you to consider hospice for yourself or a loved one if you or they are terminally ill. Unfortunately, some doctors are reluctant to tell patients about hospice because they see their roles extending life as long as possible, no matter what the circumstances, or they may fear that you will think they are giving up on you if they mention hospice. If your doctor has not recommended hospice and you are terminally ill, you can tell them you are interested, or you can simply call a hospice directly. This was a brief introduction to end-of-life care and planning and your options and rights, and so you may have questions. Next, let's review some resources. We encourage you to visit our website at endoflifechoicesny.org, where we have links to all advanced directives mentioned during this presentation and many other resources. Here, you can also learn about these and other relevant topics and see our other presentations and upcoming events, or contact us. Another resource is the Conversation Project. The Conversation Project is a public engagement initiative with a goal to have every person's wishes for end-of-life care expressed and respected. On this website, you can find tools to help you plan for the end of life and have conversations about your wishes. For example, the Conversation Starter Kit is a free resource to help guide you through having conversations with your loved ones about your and their end-of-life wishes. To access these tools, please visit theconversationproject.org. Another resource is MedlinePlus. MedlinePlus is the home of consumer health information from the National Library of Medicine, a funder of this program. Imagine MedlinePlus as your new health information Google. It contains a wide range of information, including health topics, drug and supplement information, videos and health quizzes, a medical encyclopedia, which is searchable and browsable, clinical trial information, easy-to-read health information, a directory to find local health practitioners and organizations, and information in over 45 languages. Most importantly, there are no advertisements or endorsements ever. MedlinePlus links to trusted health resources, including the National Institutes of Health, Centers for Disease Control, Mayo Clinic, and Nemours Foundation. This is an example of a health topic page focusing on end-of-life issues. Notice the table of contents. Here you can quickly skip to subjects like diagnosis, find an expert, and more. And of course, you can always scroll and browse the entire health topic. MedlinePlus doesn't create its own information, but gathers it and organizes it. Rather than doing an internet search where you go to the Mayo Clinic, then to the American Academy of Pediatrics, the information has already gone through strict standards before being included, and the source is always cited. Most local libraries also have a community health program. Please contact your library to ask about this resource. In addition to resources available at the library building, you can also access health-related articles, books, and movies online by visiting your library's website. For example, here is the website for the New York Public Library online resource. You can find this by going to nypl.overdrive.com or visiting nypl.org. As I mentioned in the beginning of the presentation, this program has been funded by the National Institutes of Health's All of Us Research Program. This program aims to build one of the largest, most diverse collection of data of its kind for health research. The goal is to have 1 million or more diverse volunteers nationwide who will sign up to share information over time. This program aims to help researchers understand more about why people get sick or stay healthy, By looking for patterns, researchers may learn more about what affects people's health. The All of Us research program will be a resource for many different medical studies and is a cornerstone of the Precision Medicine Initiative. To learn more about the All of Us research program, please visit www.joinallofus.org/NLM. Before I finish the presentation, I want to invite you to provide feedback. We are always trying to improve our program and want to hear your thoughts. Please take a moment to complete our anonymous online survey linked below in the presentation description. If you have any questions, please feel free to reach out to us at info@endoflifechoicesny.org or 212-726-2010. Thank you for watching our presentation and taking the time to learn about your end-of-life care options and rights.